Dr. Shankar is there, sir, from
Yeah.
Gulbarga. Dr. Antani from Pune has joined.
All the bigwigs of API are there, sir, today.
It's a good day, that's why.
Absolutely, sir.
So we will start, sir. All of us have joined.
Sure.
Yes, please.
Yeah, please.
Yes. Good evening to one and all. I heartily welcome all participants, physicians, other faculty members, colleagues, and practitioners, others who have joined this virtual meeting from whichever place you have joined for this World Hypertension Day program. On behalf of MESART, ACP India chapter, and API Gulbarga, I heartily welcome Dr. P.S. Shankar, Professor Emeritus, RGHS, and Cabin Institute of Medical Science, who needs no introduction. I welcome Dr. Muruganathan, Governor, ACP India chapter from Tirupur, and past president of API, and so many other organizations, for accepting our invitation to be the guest of honor for today's inauguration. I also welcome Dr. Jayant Antani from Pune, founder person of Gulbarga API Association, MESART, and a close associate of all our faculty. I welcome Dr. Shuraj Alshetti, Dr. Murgesh Pastapur, API Gulbarga, and whole family. And our guest faculty, Dr. Siddharth Shah from Mumbai. He is the Executive Chairman, Hypertension Society of India, and past president of API, Hypertension Society India, and so many other organizations. His schedule did not permit him to come to Gulbarga for our earlier invitation, but COVID-19 pandemic made him to join virtually this time. In this bad time of COVID era, when whole country and world is affected in difficult situation, I salute the COVID warriors and healthcare workers for rendering their services in spite of so many hurdles and sacrificing their lives in this bad time. I also welcome our faculty, Professor Venkat S. Ram, Director World Hypertension League, Texas, USA, presently in Apollo Hospital, Hyderabad, who has a special affectionate to Gulbarga as a close friend of late Dr. Muralidhar S. Rao. We invited him earlier to deliver Dr. M.S. Rao oration, but his schedule did not permit him to come to Gulbarga. And lastly, our faculty, Dr. Gurpreet Wander, Professor and Head Cardiology, DMC Heart Institute, Ludhiana, and past president of API, and so many other organizations. In fact, when he was a national president of API, we had invited him to inaugurate our state Capicon 2016, but his schedule did not permit. All the three faculty, in spite of their busy schedule, readily accepted our invitation to join the meeting virtually. In fact, we are lucky enough to see all three great personalities and luminaries and authorities in the field of hypertension whose CV runs in pages. Let us utilize their time by hearing and exchanging knowledge on topics of hypertension on this World Hypertension Day. I once again welcome one and all who have joined for this program from wherever you have joined. Now we will have a virtual lighting of lamp and formal inauguration.
Good. बस फोन ऑन रखिए.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Now I request Dr. P.S. Shankar, guest of honor, to address the gathering.
Thank you. Dr. Muruganathan, Dr. Siddharth, Dr. Vander, Professor Venkatram, Dr. Antani, colleagues and friends. We have assembled here to celebrate the World Hypertension Day. The World Hypertension League annually promotes the World Hypertension Day, and the League is an umbrella organization composed of 85 hypertension societies and the leagues from all over the world. And the theme for this year is to measure your blood pressure, control it, live longer. Though it is held on 17th May every year, this year it had to be postponed to October 17 today due to the COVID-19 pandemic. And the theme has been selected looking at the global statistics that has indicated that less than 50% of adults with hypertension or treatment with antihypertensive medication worldwide are aware that they have high blood pressure. There is an urgent need for awareness about the hypertension disease and its prevention and detection and control. The aim of Hypertension Day is to make people aware of the symptoms of hypertension, encourage them the measurement of the blood pressure regularly, educating the people about the early prevention of the hypertension and highlighting the prevalence of hypertension in the society. Often we consider hypertension as a silent killer because many people who suffer from hypertension are not aware that they have it, as it can remain asymptomatic. Many a times it is recognized only after suffering a heart attack or a stroke. Unhealthy lifestyle affects the blood pressure and increases the risk of developing hypertension. Life is becoming complicated. We are leading a busy life with associated stress and tension. It leads to the development of hypertension. It affects the health of the individual, increases the risk of the heart disease, stroke, and death. Blood pressure can be regulated through the diet, lifestyle, before it reaches a situation of hypertension. Regular physical exercise, medication help in reducing the high blood pressure. Avoidance of 5 S, they are very important. They are the stress, salt, smoke, spirit, and sedentary life. We have to develop strategies to manage these things. Dr. Alsetti, Dr. Sangram, Dr. Murugesh, they have taken a lot of pains to organize this virtual meeting, and I am happy to inaugurate it. And the virtual program has made me to share the platform with Dr. Sigrath and after a long time with Dr. Antani, and I am happy about it, and thank you.
Thank you. Thank you, sir.
Thank you, sir. Now I request Dr. A. Muruganathan to say a few words of the inaugural address.
Yeah. Thank you, Dr. Sangram. Most respected seniors, Dr. P.S. Sangar, Dr. Jayant Antani, and our API. Professor Siddharth Shah, Dr. Venkatesram, my friend, Murugesh, and my dear friends. It gives me great pleasure to join all of you on this World Hypertension Day. One thing is, COVID has given, as somebody said, it has brought so many people together. In fact, we are looking forward to meet Dr. Siddharth Shah, Venkatesram, Purvidip Wander, all in Tamil Nadu Epicon meeting. So this is a forum where we got stalwarts. So we are all eagerly waiting for their comments. But only one comment. In the COVID times, if you control the blood pressure, the morbidity is as equal as normal. So make sure people control blood pressure. The control blood pressure, in India, the control rate is only 10%, 10 to 12%. So I think more than medicines, more than anything, we must make sure this control is achieved by 5 M's. I call it the 5 M. M is medication, then money, mentor, then motivation, and monitoring. So these are the things which are very important to control this walking bomb. As Venkatesram says, hemodynamic malignancy. Let us all together achieve this control with all our knowledge which we spread to the practitioners as well as among the public. Thank you, and I wish the program all success. Over to Sangram.
Thank you, sir, for your kind words. So with this inaugural ceremony will come to an end. Now we move on to the scientific program. I request Dr. Venkatesram to deliver his talk on new normal blood pressure and its relevance to India. I request all to type your questions in the chat box, which will be taken after panel discussion.
I'm going to share the screen. Yeah, I'm going to share it myself. Please bear with me.
Okay, sir.
Okay, I hope you can see the screen.
Yes, sir.
Actually, good evening to all of you, all my friends. For a long period of time, for several decades, we have worked together, and it is always, as Dr. Muruganathan has mentioned, due to this pandemic. It has brought all of us together to this virtual forum, and it's a great pleasure for me to be with all of you and to share my viewpoint, hoping that we contribute to betterment of health in India. Now, what has happened is Dr. Muruganathan has mentioned the blood pressure control rates in India are around 10%. Yesterday, Dr. Paul Welton, who is the president-elect of the World Hypertension League, apparently mentioned in a global web conference that the control rates in India, as estimated, are 7%. And apparently, I was not part of the program, but apparently there was a lot of talk about India and China, that unless India and China control the blood pressure, the global cardiovascular disease rate actually will not show much change, although it has decreased in many countries. So apparently there was a clarion call yesterday in various conferences for India and for China to control the blood pressure rates so that we improve the cardiovascular health of the world. And so this is a challenge for all of us. The blood pressure classification has changed somewhat in the last 4 or 5 years, and there is a new normal blood pressure based upon the data. The question always comes, which Dr. Wander knows, and Dr. Siddharth Shah, Dr. Antani, all of you who follow the literature. The reason for the so-called new normal blood pressure is not that some people made it up, but based upon what is the reason for extensive cardiovascular disease in the country and what levels of blood pressure contribute to cardiovascular disease. And it has been shown in large meta-analysis, any blood pressure that is greater than 130 is associated with excessive death. Any blood pressure less than 130 is associated with longer prognosis. Yesterday in one of the meetings, Dr. Michael Weber apparently mentioned that although we should try for 130, the dream blood pressure should be 115, and we'll leave it as a dream at this time. As you know, this is a slide showing the Indian hypertension guidelines, which have been revised nicely recently. And in the American College of Cardiology guidelines, the category of pre-hypertension has been removed and put into stage 1 hypertension. This is a slide which was used by large global guideline committees to come towards the so-called new normal blood pressure of 130. And you will notice on this slide, any blood pressure that is less than 130 is favorable to reduce the cardiovascular complications of hypertension. And there is no level, no complication that is protected when the blood pressure is greater than 130. So all these meta-analysis, number of trials, almost 60 trials now total, if you total, have shown a blood pressure less than 130 is associated with improved outcome. Now the question always comes up, is it possible? I think we should try our best to control the blood pressure to less than 130 as much as possible. I will compare this to the field of oncology. Yesterday I saw a patient who said that he had cancer. He didn't say he has cancer. He said he had cancer. That means his cancer was cured. And I can also tell you the CEO of one of the largest hospital chains in the country gave his blood for routine, and his blood count, white blood count, was 60,000. So he had acute myelogenous leukemia with positive Philadelphia chromosome, very poor prognosis, but was treated aggressively. Now he says he had acute leukemia. He doesn't say he has acute leukemia. So the same thing is happening, that with hypertension, we have to be as aggressive as our friends in oncology have done with cancer. What a remarkable improvement in various types of cancers. People say I had Burkitt's lymphoma. People say I had Hodgkin's lymphoma. People say I had breast cancer, had past tense. So that is how we need to approach hypertension in a very aggressive oncologic fashion to reach the new goal levels of blood pressure as recommended by various societies. Now, this is a chart that has been used by all guideline committees to look at cardiovascular mortality between the blood pressures of 120 to 140 systolic, between 80 to 90 diastolic. You will notice when the blood pressure is graded from 120 to 140, when the diastolic is graded from 80 to 90, there is an incremental risk in cardiovascular death and mortality. So even within the previous definition of 140 over 90 or less, you notice that there is a significant morbidity and mortality attached to blood pressures between 120 to 140, and anything less than 130 appears to be desirable. And this is all based upon so much of data that have been taken from the studies. Now, the two definitions, Dr. Siddharsha is going to talk about Indian hypertension guidelines, which have been revised. If you look at the European definition of hypertension, you look at the American definition of hypertension, it doesn't matter because the goal blood pressure is the same. So, ladies and gentlemen, and Honorable Chairman, it does not matter what classification of blood pressure that you really want to adhere to. It does not matter anymore because the guidelines suggest the blood pressure should be 130 over 80. So I think, I don't think we should waste too much time on between Europe or India or between US guidelines. I think it's really not needed. It's a waste of time because all guidelines suggest a blood pressure of less than 130 over 80. In fact, personally, I'm not a fan of staging hypertension because staging hypertension to me does not make any sense. And actually, even in the earlier JNCs have argued that the hypertension should not be staged. But anyway, people wanted to stage it. I don't know why we should stage hypertension because we don't stage lipids, we don't stage diabetes. So unnecessarily, it's complicating. So there are only two things, high blood pressure and normal blood pressure. And now all the guideline committees suggest a blood pressure of less than 130 over 80. Now, look at how India has made the mark on the world scene, but not in a good way. And this is the European Society of Cardiology, European Society of Hypertension, which have identified South Asians, namely people like you and me, as having a 40% higher risk at any level of blood pressure. So ladies and gentlemen, Europeans have identified us, Indians, as having a 40% higher cardiovascular risk at any level of blood pressure. Now, American College of Cardiology, American Heart Association has updated their recommendations. Now they have identified Asians. By the way, when they mean Asians, don't be under illusion. They're talking about Japanese or Koreans or Thailand. We should be courageous to accept that they're talking about Indians. It's Asians and South Asians is a code word for Indians. Now look at the International Society of Hypertension comment recently. Again, they have identified South Asians as having a high risk. So ladies and gentlemen and Mr. Chairman, all the guidelines have identified Indians as having a very high cardiovascular risk. And these are the data that are well known to all of you. I'm sure Dr. Wander and Dr. Siddharsha may have contributed to the analysis of this data published several years ago, that the principal driver of cardiovascular mortality in India is high blood pressure, both in men and women. Now, this is a Mumbai cohort study that I have followed very closely, and Dr. Shah probably might have been an investigator along with Dr. Pednekar. And they have looked at the blood pressure levels in almost 2 lakh persons in Mumbai and suburbs. And you will notice when the blood pressure was 120 to 130, there was a 16% increase in ischemic heart disease death. And when the blood pressure is 130 to 139 systolic, there was a 19% increase in cardiovascular death, ischemic heart disease. So ladies and gentlemen, in our own brothers and sisters, there is a high cardiovascular morbidity and mortality when the blood pressure is greater than 120, certainly greater than 130. This is a study that we completed in Apollo system. Patient presenting to the emergency room with acute stroke, undocumented by MRI and CT. And the analysis suggested the most common risk factor for acute stroke in the Indian population presenting to the emergency room is hypertension, followed by diabetes, followed by tobacco consumption. Of course, all these risk factors coexist in many individuals. Now, this is probably one of the most important slides that you're going to see, that highest cardiovascular mortality is in people with blood pressure less than 140/90. Not at 160 or 110, not about 200 or 110. The highest cardiovascular event rate is in people with blood pressure less than 140/90. That means between 130 to 140, between 80 to 90, that is where most cardiovascular complications occur. And that is the reason why you need to get away from 140 and come close to 130. A couple of comments on the importance of combination therapy, which is stressed by all guidelines. If you look at this slide, the middle green and orange are two antihypertensive drugs, A and B, 24-hour blood pressure control. But when you combine them, A and B, into the blue color, C, there is a greater fall in blood pressure. So ladies and gentlemen, and my co-panelists, combination therapy reduces the blood pressure much more than giving two individual antihypertensive drugs over 24-hour blood pressure. So right now, we don't talk about which molecule is good, but which combination is good. In fact, I had written to DCGI that they should not approve any single molecules for hypertension anymore. They should only approve combinations and not single molecules. Now, the question is, which diuretic to use? If you look at European guidelines, if you look at American guidelines, if you look at more recently the International Society of Hypertension guidelines, they all appear to suggest chlortalidone as a better choice than hydrochlorothiazide. In fact, the International Society of Hypertension actually made a very courageous statement that hydrochlorothiazide should only be used if chlortalidone is not available. And that is, I thought that was very, very courageous, bold. Because the choice of chlortalidone is based upon so many studies in the last 25 years. I participated in some of them, and so it looks like it is an important statement that the societies have made. Now, let me come to the conclusion of this part of my talk, ladies and gentlemen. The normal blood pressure definition has changed during our own lifetime. You will notice the blood pressures that were considered as normal once before are considered very, very high now. So the new normal blood pressure now, based upon all the evidence and based upon a consensus, is a blood pressure of 130/80. Any blood pressure that is greater than 130/80 is abnormal. Any blood pressure that is less than 130/80 is normal. And actually, Dr. Michael Weber yesterday in one conference argued towards 115. I will not go into that. So this is what Dr. Michael Weber has written to me, and I want you to pay close attention because we have Hypertension Society of India, we have several people from API leadership here. This is a note that he wrote to me just 4 days ago. He said, the current pandemic of hypertension is an incentive to make India a new leader in blood pressure control. And this is a very, very powerful challenge that is given to us by a global legend in hypertension, Dr. Weber. So all of us on the panel here have to take upon this challenge. A person who does not live in India, but looked at the data in India, and he has thrown this challenge to us, an incentive to make India a new leader in blood pressure control based upon his observations. So, Mr. Chairman, ladies and gentlemen, we have seen the definition of blood pressure change in our own lifetime, just like definition of diabetes or hyperlipidemia. The new normal blood pressure is 130 according to all the data. And once upon a time, it was somewhat controversial. Can we do it? But now the data are so clear-cut. The same example I gave for oncology, the two examples I gave that young man I saw yesterday, he said he had cancer, and the CEO of a major hospital chain now says he had acute leukemia. He does not say he had acute leukemia. So I think we need to have the same approach that our brothers and sisters in oncology have taken, because we're dealing with a hemodynamic malignancy, and all of us have to work towards this goal to reduce the burden of cardiovascular disease in India, because India and China are being watched very closely for the pandemic of hypertension, and all of us have a responsibility to flatten the curve and to decrease the attention on India, and that is the reason why Dr. Weber has challenged all of us that we should become the global leader in blood pressure control. So Dr. Biradar, Dr. Antani, Dr. Muruganathan, my good friend Dr. Siddharth Shah, Dr. Shankar, all of you, I offer my salutations and greetings to you and express my gratitude for thinking of me and for asking me to participate in this dialogue. Greetings and good wishes. Bye-bye.
Thank you, sir. Thank you for your excellent deliberation. Now we move on to the second talk. I request all the participants, if there are any questions, to chat in the chat box so that it can be taken after the panel discussion. Now I request Dr. Siddharth Shah, sir, to deliver his topic on Indian guidelines on hypertension, what's new. Over to Dr. Siddharth Shah, sir.
Thank you, Dr. Sangram Biradar. I must really congratulate for your efforts all these years for keeping up the Gulbarga flag, and the API and the Hypertension Society of India recognizes your efforts for these CMEs that you hold every year. Thank you for inviting me for this important meeting, where we have stalwarts like Dr. Venkatram, Dr. Wander, Dr. Muruganathan in the field of hypertension, that they have joined to enter into control of blood pressure in the country. I will talk about how the Indian guidelines on hypertension has developed over the years, and something what has happened in the last guidelines was not there in the Indian guidelines on hypertension. You will see that this is the first cover of the Indian guidelines on the management of hypertension that was released in the year 2001. Next slide, please. Next slide. Dr. Biradar, can we have? Then from there on, we had the second edition and the third edition. The thing that we will have to note is that every 6 years, we have been able to bring out these guidelines under the banner of API and Indian and Hypertension Society of India. The next slide, please. The next slide, please. This is the latest Indian guidelines on hypertension, the fourth edition, which was released in 2019. And you will observe the change in the JAPI edition, that it is being majorly contributed by the Association of Physicians of India and the Hypertension Society of India. And you'll also observe the various other societies that have endorsed these guidelines, especially the Cardiological Society of India, the Nephrology Society of India, the Obesity Society of India, and the various other guidelines and societies that have endorsed these guidelines. Next slide. The title of Indian guidelines on hypertension from 2013 has evolved and has been recommended over the years. These are the changes that you will find in the latest guidelines. Next slide. This is a very important observation over the 4 guidelines that have come forward. We have been always advocating the toxic effects of mercury, and this edition of the guidelines have emphasized that the health-related toxic effects of mercury are recognized world over, and mercury sphygmomanometers are being replaced by aneroid and digital sphygmomanometers. We intend to emphasize that the change is inevitable, and Indian physicians should also move towards using these devices and wean off the use of mercury sphygmomanometers. You will observe that in our country also the change is happening. All of us have switched over to aneroid and digital sphygmomanometers. The important thing is what is necessary is to see that these sphygmomanometers are calibrated time and again to see that they are not dysfunctioning and giving bad results. Next slide. Next slide, please.
For follow-up of patients, you change, sir.
Next slide. What was important about the Indian guidelines on hypertension was it collated the various epidemiological data all over the country, and over the 4 years we have got the new epidemiological data that is now available, and it included and reflects the increasing prevalence and poor level of control of hypertension in India. Next slide. The beta blockers has always remained in the controversy in the field of management of hypertension, and it has been emphasized in the latest guidelines over the years that the value of beta blockers as first-line agents in hypertension has receded, and these are now recommended as agents for use only in young hypertension with specific indications. For routine patients, these are no longer recommended as first-line agents. I think I must congratulate Dr. Wander for persisting this statement and bringing it out, and which is now very well recognized by all cardiologists and people treating hypertension to recognize that beta blockers are not to be used as a first-line agent for control of blood pressure. Next slide. Next slide, please. This is an important statement as far as the treatment is concerned in the 4th edition of the guidelines is that this is what Dr. Venkatram has also emphasized in his presentation, is that the diuretics are now considered at par with ACE inhibitors or ARBs and calcium channel blockers, and not as preferred agents as in previous guidelines. Chlorthalidone is now available and shown to be better than hydrochlorothiazide, and its usage is to be preferred. In the first and second guidelines, chlorthalidone was not available in the market, and that's why we did not mention about this drug in the first and second guidelines. But in the latest 4th edition of the guideline, we have emphasized that chlorthalidone is a better drug than hydrochlorothiazide. Next slide. One important premise is that when blood pressure is high by more than 20 by 10 millimeters of mercury, systolic and diastolic, it is now recommended to start with a combination of drugs. This is also emphasized by Dr. Venkatram in his last statement, that combination of drugs is important in control of blood pressure. Monotherapy is not going to be effective in achieving target blood pressure. Next slide. Certain combinations have been shown to be better than others in recent trials, especially ACE inhibitors and ARBs in combination with CCBs forms a good combination. This is a recommendation made by the committee of guidelines for the latest edition of Indian guidelines. Next slide. In the earlier guidelines, octogenarians were not considered, but in the latest guidelines, as in other guidelines, we have made this statement that treatment of hypertension, even in octogenarians more than 80 years, has been shown to be beneficial as shown by the newer data and has been recommended. Next slide. At the time of second guideline, it was felt that lower the better for control of target blood pressure. However, it has been realized now that a J-shaped curve does exist specifically for non-revascularized coronary artery disease patients, and caution has been advocated in trying to lower blood pressure to low target levels, especially in these patients. Next slide. Chronic kidney disease is now recognized as a common comorbidity and has been explained. Awareness and diagnosis of this entity will help recognize the high-risk hypertensive individuals. Next slide. Approach to hypertension and kidney disease has been revamped, and KDIGO, Clinical Practice Guidelines for Management of Blood Pressure in Kidney Disease, have been included. This was with the help of Kidney Society, and they had recommended this, and that's why this statement has come into the latest guidelines. The term heart failure with normal ejection fraction needs to be recognized by physician and has been mentioned and explained for use in clinical practice. Hypertension, heart failure with normal ejection fraction is common among elderly hypertensive individuals and is diagnosed on the basis of symptoms of dyspnea, raised BNP levels, and diastolic dysfunction on echo with normal ejection fraction. This has been recognized and has been added to the latest guidelines. Orthostatic hypotension and its clinical implications have been included because common practitioners face this problem of orthostatic hypotension, and there have been and major statements have been done to recognize this and how to treat this, an approach to the orthostatic hypotension, which has been included in the guidelines. Next, a new form of non-pharmacological intervention, sympathetic denervation therapy, has become recently available and is being evaluated. Its place in treatment of these patients will evolve over a period of time. And this, you can say that even at this stage, even this therapy has still not been modified. Next slide, please. As the statement has been made in the Indian guidelines of hypertension 1, we tried to emphasize that the endeavor for bringing out the guidelines is not being to reinvent the wheel, but to highlight certain differences in the Indian context. These guidelines, along with the other available, should therefore be of value to all physicians in India who manage patients with hypertension. I'm happy to note at this stage also that the pre-hypertension, which was mentioned in the first guidelines, has been given up, and we have been a staunch promoter of removing the pre-hypertension, which has been recognized by all the countries, and this term of pre-hypertension has been removed from all the guidelines. And we must thank the whole committee consisting of Dr. Wander, Dr. Aspi Bilimoria, Dr. Sandhya Kamath, Dr. Venkatram and Dr. All other who have been contributing to this edition of Indian guidelines on hypertension. Dr. Munjal has also been very, very proactive in attending all these meetings and giving his guidance for these guidelines. Dr. Wander, I must mention, has been proactive in driving the whole committee to bring out the guidelines in time, that is every 6 years. We hope to do so in the future also. Thank you.
Thank you, sir, for your excellent deliberation on hypertension Indian guidelines. Now I request Dr. Gurupit Wander to take over for panel discussion.
Well, very good evening to all the stalwarts of the API and Hypertension Society of India. And it's a rare day, actually. I must appreciate your efforts, Dr. Sangram Biradar, for having been able to get two of the stalwarts of this country, I would say of the world, actually, to talk in the same session. I remember way back, actually, Dr. Venkatram and Dr. Siddharth Shah were course directors for one of the sessions on hypertension about 15 years back. And I had the good fortune of one of the speaker as a speaker, actually, as their choice. So today it is again a very rare day that two of the people who have contributed enormously in the field of hypertension are actually with us. Dr. Siddharth Shah has been associated in coining the Indian hypertension guidelines. And as he has shown in 2001, actually, the first Indian hypertension guidelines were then released by Mr. Atal Bihari Vajpayee in 2001. And then he has been instrumental in bringing, actually in India, they were the first guidelines on any disease, so to say. Just as it is said that the JNC guidelines were one of the first ones in the world, actually, on any disease. Now we have guidelines for management of various. We live in an era of evidence-based medicine, and so much data, so much meta-analysis comes that it really needs and demands the expertise of stalwarts like Dr. Venkatram and Dr. Siddharth Shah, analyze this data and put it in a simplistic manner for a practicing physician as to how do I manage my patients. Subsequently, the Indian hypertension guidelines came in 2007, in 2010, and in 2019. In fact, last 3 years have shown significant changes in the way we look at hypertension. And as Dr. Venkatram beautifully showed, the Americans in 2018 actually virtually changed the whole concept of management because they brought in a new definition of 130/80 as compared to the European, the ISH, the Indian, and various other guidelines which still stick to 140/90. And Dr. Venkatram often says that we should not actually burn our blood in trying to look at who says what level of blood pressure is high, because we have come to realize that within this, as he beautifully showed, that it is people between the range of 130 to 140 systolic and 80 to 90 diastolic, where most people who sustain, because that's the area where largest population of individuals actually is, and that is the reason that you have people suffering from cardiovascular consequences because of this. We all know the sprint trial came a couple of years back, about 5 years back, and that is what actually changed the way we looked at hypertension, because we realized that if we are more aggressive in terms of management, actually at the same time, more and more drugs, and as Dr. Venkatram and Dr. Siddharth Shah pointed out, we realized that blood pressure can be brought down with combination therapy only, and not with individual solitary drugs. And now we are able to achieve actually those levels. Before actually we have questions from the house, and I open it, I just have one question actually. what is the interpretation of the two stalwarts on, we had the ACCORD trial, which looked at the diabetic population. We have always said that it's the diabetic population which is more at risk, because hypertension and diabetes are close cousins. They are components of the metabolic syndrome X. They tend to occur together. But we always thought in diabetics, which is a higher risk subset of patients, when we will manage their blood pressure more effectively, since they are a higher risk subset, we will be able to impact mortality to a greater extent. But the ACCORD trial was, although it was a smaller study, did not show a significant reduction in events when we brought the blood pressures to 120 as compared to blood pressures of 140. But it's the SPRINT trial, which was an NIH study, which showed us that lower pressures are more effective in controlling and in reducing the target organ damage. So what went wrong with the ACCORD study? I would like to request Dr. Venkatram to take it first, and then maybe Dr. Siddharsha, who's a diabetologist also, he can give his impressions on how do we manage actually in diabetic patients? Where do we stand today as compared to non-diabetics and diabetics? Dr. Venkatram sir, please.
Thank you, Dr. Wander. You have raised a very important aspect.
Dr. Venkatram, you have to unmute yourself, sir.
Thank you, Dr. Wander. Yeah, as far as diabetes is concerned, he has brought out a very important problem. We all know that almost 50% of hypertensive patients are diabetic, and also 50%, more than 50% of diabetic patients are hypertensive. In these times of corona, we have found that diabetic patients, along with the comorbidities, including the cardiovascular disease and hypertension, when they have assessed the percentage, they have found that in diabetic patients, those having hypertension are almost 50% having mortality risk when they have found that these two exist together. So even in the corona times, it has been emphasized that diabetic patients and hypertensive patients are a bad combination for corona scenario. The other part is that as far as the diabetic and hypertension, it's a deadly combination, we can say, and the drug of choice in a diabetic patient remains still the ACE inhibitors and ARBs as the first choice for the control of hypertension, as all trials have said. And the best combination for hypertension in a diabetic would be ACE inhibitor ARBs, and if required, the calcium channel blockers is recommended for the control of blood pressure in a diabetic scenario. Thank you.
Gurpreet, just to supplement what Dr. Siddhartha has said, because he also wears the hat of being a very important clinical diabetologist in the country. The ACCORD trial, because people expected overwhelming benefit. The expectations were this is going to be the overwhelming benefit. But what it showed was at the level of blood pressure, there was no benefit for coronary artery disease, but actually there was a benefit for stroke. So ACCORD was not a negative study the way the press and people have interpreted, but it was not as positive as people had hoped. They said you are taking the highest risk and therefore you will show the greatest benefit. It's just like somebody jumping off from a high building. They jump at a faster rate and you think that they'll jump and then they will injure themselves. So same thing with these expectations very high. But ACCORD was really for a clinician, it was a positive study no major benefit on coronary artery disease, and people say that it was not statistically powered to look at it, but there was a benefit on stroke, which brings to the conclusion blood pressure is of paramount importance, because once you reduce the stroke. So now the other study, which was not, I mean, it is well known in India, hypertension optimal treatment trial, HOT trial, clearly has shown that the diastolic blood pressure less than 80, between 70 and 80 was beneficial to diabetics compared to 80 to 90, 90 to 100. So I don't think that we should let loose diabetes people to have higher levels of blood pressure. No, not at all.
Well, thank you for the audience. Both stalwarts feel that diabetics are a high risk subset, and the targets that have been delineated for the non-diabetics, they equally stand for the diabetic population. And in fact, since they are a higher risk, and as Dr. Venkatram very beautifully said, actually it's the trial was not powered actually for the numbers, and it is believed that if they had a larger number, they would have reached. Some people have done subgroup meta-analysis. If you look at the sprint kind of patients in the ACCORD trial also, then you find similar benefit as the sprint trial. So almost the data actually speaks in the same direction if you look at that subset of patients. One more question actually I wanted to ask Dr. Venkatram here. I personally feel actually the pendulum has shifted, because initially we used to look at diastolic hypertension more, but what we today actually look at is the systolic hypertension, because we know as we age, it's the systolic blood pressure which goes up, and it's the systolic hypertension management. So where are we in terms of diastolic hypertension, sir? Because we are always talking about the systolic hypertension target of 130. Look at any guidelines. How does a clinician actually, because there are still some patients who are in their 30s and 40s who come with a blood pressure of 140 by 100. I mean, how as a hypertension expert do you look at, and what message would you like to give to everyone in the audience, sir?
Thank you very much, Gurpreet, and others can also join me if they disagree. First of all, I feel a little bit embarrassed when you refer to me as stalwart. I'm in infancy of my career. I'm still looking forward to a future. My future is still in front of me, not behind me, I hope. So, but I'll tell you why the systolic hypertension got more emphasis than diastolic blood pressure, because that is where the greatest benefit was. When you reduce systolic blood pressure, you reduce the risk of stroke by 60, 70%, significant reduction, because of all the complications of high blood pressure, only stroke is totally blood pressure dependent complication. Whereas coronary artery disease has multiple risk factors, CKD has multiple risk factors. But if you look at brain, the major risk factor for brain morphology or pathology in the future is always blood pressure. So that is the reason why. And all the studies have shown that when you treat hypertension, systolic blood pressure goes much to a greater proportion than diastolic. And that's the reason why people thought systolic is more important than diastolic, because it is falling. Whereas diastolic, if you treat somebody with 180 by 90, it can become 140 by 86, but it won't become 140 by 60. And therefore, people thought the systolic blood pressure is more important than diastolic, because this is a very simple principle of physics. Higher the pressure, greater the drop. Lower the pressure, lesser the drop. That is simple physics class, first biophysics class. That is the reason why people thought, but both systolic and diastolic are equally important. In fact, there is we must acknowledge our own data from India. We must always be proud of Make in India data. We can always be proud of the soil which has given us free medical education. At least for me, medical education was free. I didn't pay even 100 rupees for Usmania Medical College. Everything was free, including library. I can be there till midnight, zero fee. So what I'm trying to say is there are data now that is coming up from India, which showing high diastolic blood pressure in young people, which is responsible for complications. We published a study in the Journal of Human Hypertension, isolated diastolic hypertension in rural India as a predictor of cardiovascular prognosis. So I think systolic and diastolic are equally important, but systolic blood pressure is easily measurable because you don't need stethoscope also to measure systolic blood pressure in the office. So I think both are important. I don't think one should deal in isolation. One comment I have, which Dr. Siddhartha has mentioned about mercury sphygmomanometers. My personal opinion, which doesn't count now because we are totally overwhelmed by WHO directive, there was not enough evidence that that kind of a mercury did anything. But now the problem is the world is banned basically. One comment I have, if young people are listening, is that if you publish a paper or submit a paper for publication in which in the methods, if you say the blood pressure was measured with mercury sphygmomanometer, you get a very low rating by the reviewers, almost to the point of rejection. So be mindful of that. Although by the way, I tend to behind the screen, I can also cheat. I do have one, okay? I do have one. So for people who want to write papers, don't mislead them, but it's a negative if you say that if you measured it with mercury sphygmomanometer.
That's a useful advice, and also we realize, and for the audience, systolic and diastolic hypertension both are equally important. And as sir said, for the younger population, diastolic is actually more prevalent, but as we age, the systolic becomes more. So you keep listening to the systolic, but Dr. Venkatram showed us actually that there is data, he says, from our own country, which we should be proud of, and which shows that diastolic hypertension needs equal treatment. One question I wanted to ask Dr. Siddhartha, sir, if you recollect, when we had the second Indian hypertension guidelines, that time the largest trial, the ALLHAT study came. In fact, it was the largest study, even till now, the highest number of patients ever to have been taken in a single study. And the ALLHAT showed us actually that it's the numbers which make a difference actually. And if you look at the World Hypertension League actually also, for the last 5 years, the World Hypertension Day actually motto was know your numbers, because what they wanted to tell people was that you should know what your number is. Awareness regarding hypertension. Dr. Shankar mentioned in the beginning that only people feel that in our country, less 50% people who have hypertension, they are aware of it. So it's just required is to know your number. But this year they changed that and they emphasized that you have to measure your blood pressure accurately, control it, and this will make you live longer because we have enough data that accurate measurement of blood pressure is important. So coming to Dr. Siddhartha, sir, this question you mentioned about the accomplished trial, which you showed that a RAS blocker in combination with a calcium channel blocker was found to be somewhat better than a RAS blocker with a diuretic. We at that time emphasized in the guidelines that it's the number which makes a difference. If you are still, a lot of experts say that if you are able to control blood pressure to the desirable numbers without producing any side effects or without making a person feel worse, that is what makes a bigger difference. But a lot of us actually bother about what drugs we are using, because we do realize, and it's been put into our mind, that when we use beta blockers and diuretics, new onset diabetes comes up, and we as Indians have metabolic syndrome. Probably it even gets exaggerated to a larger extent. And so these newer agents, so to say, as was shown in the ESCOT trial also, that the ACE inhibitor with a calcium channel blocker forms a very good combination as compared to the earlier two conventional drugs, the beta blockers and a diuretic. So what is your practice today as a clinician? Since you see hundreds of patients of hypertension, do you look at the numbers that we try to achieve that we emphasized in the earlier guidelines, or you are still drug-centric in terms of what combinations you use and how kind of make these combinations, sir?
Thank you, Dr. Wander. I think it is important to understand that various trials have shown that single drug is not going to control the blood pressure. And hence we have to combine the drugs, and we should try to find out which drug combination will suit the patient most without causing side effects. And that is why over the years, we have been thinking whether the ACE inhibitors and ARBs can be combined with a diuretic to reduce the cost of the long-time treatment or lifelong treatment of hypertension in patients. But then if we are thinking, the latest trials that have shown is that the calcium channel blockers can replace the diuretics in combination with ACE inhibitors or ARBs to give a desired results without side effects of metabolic problems that the diuretics can cause. And that's why we do choose, in even real world practice, we do choose ACE inhibitors and ARBs as the first drug of choice in a diabetic and combine the calcium channel blockers along with it for optimal control of blood pressure.
Thank you, sir. Before I open it, actually, I would request all, I can see some very big names on some very astute physicians actually in the audience. So I am going to ask one last question before you can all get into this kind of, it's not necessary that you ask questions. You can make your own comments because we all manage hypertension. And today is a very rare day when we have two experts, Dr. Siddharth Shah, Dr. Venkatram with us. So we must avail this opportunity. But if Dr. Muruganathan is there, Dr. Muruganathan, you have been a proponent of home blood pressure measurement. And Dr. Venkatram sir just mentioned about the method of measurement. I actually take a lot of interest in the blood pressure measurement because I feel something that you can measure, not measure accurately, how will you be able to manage it effectively? And I personally have very strong opinions because people ignore measurement of blood pressure to a very large extent. So I'm very satisfied that a stalwart like Dr. Venkatram did touch upon how to measure blood pressure. But Dr. Muruganathan, you actually depend a lot on home blood pressure. If I can make a comment, when we did the first Indian hypertension guidelines, Dr. Siddharth Shah will bear with me. At that time, we felt that home blood pressure apparatuses are not available in India and people were not tuned to it. And data was not there. At that time, we did not encourage home blood pressure. But since the third guidelines, we have been emphasizing, so similar to the work that we must encourage home blood pressure measurement because we can diagnose white coat hypertension and masked hypertension. And we all realize that white coat hypertension is not harmless. It is half as harmful as sustained hypertension. And a lot of these people actually subsequently go on to develop hypertension. Masked hypertension, in fact, when the home blood pressure is high, but the pressure is normal, is actually, people believe, more harmful than sustained hypertension because it gets neglected. Dr. Muruganathan, would you like to make some comments on your favorite topic of home blood pressure measurement and guide some of the youngsters here as to how best we should utilize this modality in our clinical practices? I think he's, Dr. Muruganathan, are you with us? I think we've lost him. Can I request you, Dr. Venkatram, what is your clinical practice in terms of how frequently do you advise them to have an apparatus at home and how much do you depend clinically, although we all emphasize actually in the guidelines that it has to be done. So what is your take on the home blood pressure and the ambulatory blood pressure, since you have been working you have the actually unique experience of having worked with Norman Kaplan, and all the big trials actually came from your center. So ambulatory blood pressure usage in, I think, some of the Western countries has been higher. You've been practicing in both these scenario. So what is your take on these methods of measurement of blood pressure, sir?
Yeah, okay. Home, first of all, the topic of home blood pressure measurement of blood pressure has resurfaced due to the current pandemic because of less contact that people are trying to have with each other as much as possible, although it's not ideal. Although I think there is a possibility of home blood pressure measurement being a useful tool, but there are several unanswered questions. Number one is, by the way, I'm not a critic of home BP, but on the other hand, I'm not sure how it will help day-to-day practice. There is no standardization on measurement of blood pressure at home, sitting position, how many times you should take, and the relationship to the meals. Because there is a phenomenon called postprandial hypotension, where after you take a good meal, there is an increase in splanchnic blood flow, and therefore decrease in cardiac output, and the blood pressure falls. Not syncope, blood pressure, syncope can also happen. So the problem is we don't, how to use the home BP and mentally alert yourself as if you have taken it. That is the thing. How to equate it that you are so confident that you have taken it. That people take home BP, we have no control, with all due respects to them, by the way. I'm not saying they should all be PhD in blood pressure measurement methodology. I'm not saying that. But what I'm saying, for example, if I ask Siddharth or you or Muruganathan or Dr. Antani right now, when is the last time you made the final diagnosis of hypertension on home BP? And when is the last time you reduce the blood pressure medications because the blood pressure has come down? Or when is the last time when you increase the medications? The answer is going to be that you will not be able to tell. I mean, I'm unloading your answer. So that is the problem. So home BP requires a little bit more of standardization in the future with standard equipment, standard posture, so that the doctor feels that he or she is taking it. Right now, many of us are not sure whether you want to treat somebody who says my blood pressure is 150 by 100. We always tell them usual response, knee-jerk response is measure it every week for 2 to 3 weeks and let me know. Then what happens? You lose the patient. I mean, that is very common. So this is the drawback. Whereas ambulatory blood pressure, I'm saying it respectfully, you have full control over the patient. I use the word control in a very respectable fashion, as a captive. But now what is happening is, not for any company, India being a technology place, there is more availability of cuffless BP in India than any other country. And it is not as expensive as people think. Angioplasty and stent are more expensive. Dialysis and kidney transplant are more expensive. ICU is more expensive than this. So I think I prefer myself ABPM a little bit more than home BP. And the new technology, ABPM, don't be afraid of it. We checked it out, correlation coefficient is 99%. We're about to publish a study using cuffless BP technology and blood pressure fall with combination therapy. And it seems to come down. So between home B and ABPM, I would prefer ABPM. But on the other hand, now all the organizations, and Siddharth will attest to it because he must have reviewed the guidelines when you all wrote yours, they recommend now automated office blood pressure measurement. That means the patient could be in front of you, doesn't matter. Could be sitting across the desk, but still he's hooked in automated office blood pressure measurement. And many devices are available which take average of 2 or 3 readings. And you have to believe it. And you have to believe it, they're not wrong. There is a reason, you should have a reason not to believe it. If you don't have a reason not to believe it, you should believe it. So this hesitancy of using digital technology should go back, and one should be a little bit more and use it. I know that I gave you a very convoluted answer, but at least I hope that some message has come through.
Sir, it's a very practical and a very actually it's a very useful answer for me because it just tells us how you look at this, and we value your thoughts much more than any group of experts. In fact, AOBP was used, as you have introduced now to this audience, in the sprint trial, and some people believe that the automatic office blood pressure, as sir is saying, the readings are about 7 to 10 millimeters lower than the office readings that we take. And I can recollect many years back, actually, one of these meetings which Professor Siddharsha had organized. Dr. Ashok Kriplani gave a talk on the true BP he had at that time. And the true BP actually exams to do this. That's the first time you must have used this equipment long time back in US, Dr. Venkatram, but he got it from the West, and he used to use this true BP. And in one of these meetings I heard, and the idea looked fascinating. But now, as Dr. Venkatram is saying, the automatic office blood pressure recording is something that we should all be familiar with, since we are, he says, we are a technology-driven country, absolutely right. But then we are also living in a technology-driven era also, sir, world over. So these things are going to come up, and we will be using them more and more often. I open actually the discussion for any one of you to come in.
Sir, may I comment? May I come in?
Yes, sir.
Dr. Wander, we talked about the various types of BP instruments, but what is most important is that all the blood pressure monitors that you may use, that has to be calibrated. I don't think if there is a calibration is not proper, you are not going to get good readings, and that is why I would emphasize that all the blood pressures monitors that we are going to use in future, there should be some mechanism whereby these meters has to be calibrated for finding out whether they are giving the required results. And there are mechanisms by which we can calibrate these meters, and that is important.
Very well taken, sir. Actually, sir is trying to emphasize to all of us that especially the aneroid apparatuses as compared to the mercury, actually, aneroid ones really need calibration because they are based on a spring, and that spring does not actually hold on for a long period of time. So word of caution from our stalwart, Dr. Siddharsha, sir, that if you use aneroid apparatuses, make sure you are calibrating these every 6 months, because otherwise they will give you wrong readings and you will be managing patients.
Wonder, I'm
Sir.
Dr. Nathan. Can I give a comment?
We are looking for you, and we called up for you. You were missing, sir. But
Okay.
first, give a comment on home blood pressure, and then give whatever comments you feel like, sir.
Okay. See, actually, I asked one of the senior doctors. He was asking me where we have to get the validation. I said, you are in a small town, you'll have to go to Bombay, Chennai, like that. Then I asked him, what car you have? He said he's got Maruti car. And asked him, how do you, when do you change the car? Once in 3 years. Why? Because it'll get kharab ho gaya, problem, that's why. So 6 lakhs rupees a car, you are changing every 3 years. It's only 2,000 rupees. Don't worry about validation. Buy every year, change every year. Very simple, because that's the message I gave him. Because unless you get a validation, it's not going to be useful. But every time when you buy new, they'll make sure that they give a validated monitor. That's one. Number two, every doctor has got a BP apparatus, but unfortunately, they don't have 3 cup sizes. They have only 1 cup size. If a Motawala comes, they don't have a measurement of the BP, correct BP. So I tell them, even if you don't buy a monitor, at least buy 3 cups, 3 different size cups, so that it will be useful. When a lean person comes, when a motor person comes, it is useful. And then coming to your home blood pressure monitoring, now every guideline says home blood pressure monitoring is useful, whether it is elderly, whether it is pediatric, whether it is pregnancy. So especially in lockdown, home BP monitor was very, very useful in controlling hypertension. In the COVID times, it is very, very important that everybody should have home BP monitor, because they have chance of developing hypertension because of the anxiety, because of no exercise, because they don't have medicines for they buy only 15 days medicine. They don't go out for the fear of COVID, and they don't take medicine. So because of that, I called it as a lockdown hypertension. So in that situation, home BP monitor is a must.
Thank you, sir. Thank you for your words of wisdom. Dr. Jayant Antani, sir, we want your comments on all the panel discussion. These two experts have been discussing. You are a stalwart in the field of medicine. So let's hear what your thoughts on, sir.
I think very much the device must be calibrated. That is very important. And secondly, the devices, the blood pressure measurements where several devices are several readings. In fact, the patient comes to me and I check with mercury manometer, and the device shows very high or very low. That is a problem with many doctors, they are telling me. There have to be something by control or by validation has to be done.
Gurpreet, I have a comment. Actually, we must acknowledge Dr. Siddharth Shah's friend, and we also know him, Ashok Krilpani, who has utilized True BP very nicely. In fact, I have learned from him quite a bit. Myself and Dr. Siddharth Shah invited him to one meeting in Pune where he demonstrated, and I learned from him a lot. The other thing is Dr. Jayant Antani appears to be a very modest individual, but he has done wonderful studies for a number of years looking at antihypertensive drugs and regression of LVH on using echocardiogram from his center in Gulbarga, not from AIMS, not from Medanta, not from Apollo, not from Fortis, but in a place, Gulbarga. So I have a lot of respect for Gulbarga. I've been there. Wonderful doctors are still there, and many of them are here. So I want to offer my tribute to Dr. Antani and a number of people from Gulbarga who have made it an academic center in their own practices without this big background of a huge, expensive medical center.
Thank you, sir.
Thank you, sir.
Anybody else has comments or questions?
What about currently the diabetic hypertensives? Sir, Wonder sir, or Dr. Siddharth Shah can come in. The SGLT2 inhibitors, what is the role at current scenario?
Dr. Siddharth Shah is, I think, the
Diabetic hypertensives.
Yeah, sir, please.
I think we have already emphasized about the ACE inhibitors and the ARBs for the control of blood pressure in diabetics, their role. And I think these are the best first-line drug for control of hypertension in diabetics.
Thank you.
To answer this, actually, sir, the SGLT2 inhibitors are now actually going to become cardiac drugs. They will no longer remain diabetic drugs, because the DAPA-HF study shows that the reduction of mortality in heart failure with reduced ejection fraction is very significant. So this is now considered as the fourth arm, and 50% of the patients in the DAPA-HF trial were non-diabetics, 50% were diabetics. The benefits it imparted were similar in the diabetic and in the non-diabetic population. It's not just due to the blood pressure control, it's due to multiple other effects that SGLT2 inhibitors have, their vascular benefits, the natriuresis. But I think you are right, these agents we use, the diabetologists have been using them for almost 4 or 5 years now, but it has now reached the anvil of the cardiologist, and even there are significant studies showing now that in CKD also, in the non-diabetic CKD also, especially the proteinuric CKD, the Credence trial showed actually that it is beneficial. So these agents we are going to hear much more about them in the cardiac ambit and also nephrology ambit.
One comment, Wonder, when somebody is already taking SGLT as a diabetic hypertension, they have to titrate the other antihypertensives, because considering this has also got some antihypertensive effect. So that way it's good. Yesterday I saw an article, these drugs are also given in the BP variability. It's a very new article, but they say, as you rightly said, it has become a cardiovascular drug than a diabetic drug.
Right. And BP variability is one of the parameters for increased mortality. So
Right, sir. Right.
inter-visit variability and even otherwise BP variability over a short period of time. Both have been shown to be.
Right, sir. Very.
We hand over to Dr. Sangram Biradar for the conclusion of this panel. And I must thank, today has been a great day for me. I could get opportunity to speak to two of the most respected stalwarts in the field of hypertension who have contributed enormously in this country. Dr. Siddharth Shah has been bringing out the Indian hypertension guidelines, and words cannot express the respect I have for him. He has been mentoring so many of us physicians all across the country and has been a pathfinder for all of us in the Association of Physicians of India. So thank you very much, sir. It's a great honor actually to participate in a session with you, sir, for me personally. And Dr. Venkatram has been involved in the JNC guidelines. We have all seen his editorials on various guidelines and is one of the most respected Indians world over. Why? He is the most respected Indians world over in the field of hypertension. And I actually feel we are lucky that he's now living in India after having spent 35 years at the center of hypertension in the world. In fact, I was reading his obituary to Norman Kaplan, for the European journal, the European Heart Journal, where he has mentioned some of these significant studies, articles, and some of the things that we consider as pathophysiological mechanisms in hypertension, where he attributed, he also talks of his personal life. So two greats, and always a pleasure. Dr. Muruganathan sir, always very well read and always tells us about the latest in this field. And Dr. Antani sir, I was not aware that you have done pioneering work on left ventricular hypertrophy regression in hypertension. So thank you for having participated. It was pleasure to hear Dr. Shankar's voice. We all respect him enormously in API, and we have all listened to his talks. So thank you very much. And over to Dr. Sangram Biradar for the conclusion.
Thank you, Dr. Wander.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Biradar. Thank you, Dr. Wander, Dr. Venkatram, for all. It is a pleasure to be with you all.
Thank
and
you, sir.
Gulbarga takes its own place.
Thank you, Dr. Shah and Dr. Venkatram.
Thank you, Dr. Siddharth Shah, Dr. Wander, Dr. Venkatram, sir. Thank you. Namaste.
I thank Dr. Gurpreet Wander for his wonderful conducting of panel discussion. I also thank Dr. Siddharth Shah for accepting our invitation to spare his valuable time in spite of his busy schedule. And I also thank Dr. Venkatram sir for joining us and updating. The house has no questions at all because both of you have made the subject so clear that there are no questions at all. And I also thank Dr. Muruganathan for his expert comments and our own faculty, Dr. Antani sir, to be with us on this World Hypertension Day. I once again thank all the faculties, all the delegates who have joined from all over the country. I thank one and all for being with us. Thank you, one and all.
Dr. Biradar. Thank you, Dr. Biradar.
Thank you, Dr. Biradar.
Thank you, sir. Thank
you, sir. Thank you, sir.
So we close for the day. Thank you, one and all.
बैटरी जती है